Hello and welcome to the latest edition of WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. When your child has a brain or spine problem, you want the best, most advanced care you can find. The good news is, state-of-the-art treatment for newborns, infants, children, and teens can be found right here in the Mountain State. Today, we're talking about pediatric neurosurgery treatments with Dr. Kimberly Hamilton, neurosurgeon at WVU Medicine Children and the WVU Rockefeller Neuroscience Institute. Welcome, Dr. Hamilton, to Tuesday Talks.
Thank you. It's nice to be here.
It's good to have you. Now, we do encourage questions from our viewers, so feel free to post your pediatric neurosurgery questions in the comment section, and we'll try to answer them for you live. Okay, so let's start first with some basic things here. You are a pediatric neurosurgeon, so what are the most common conditions that you treat as a pediatric neurosurgeon?
This is a great question. I think one thing that's important to know about pediatrics is that it's separate training. And so I had to not only go to medical school to become a physician, which is the foundation for everything that I do, but then I completed training for neurosurgery to learn how to do all of the surgical techniques and to care for the problems that we see. In that training, I saw adult problems, I saw pediatric problems, and really enjoyed taking care of the pediatric patient population. So that becomes a secondary subset of my training after completing the neurosurgery track to be able to care specifically for those pediatric problems. In kids, we definitely see a different content or makeup of what problems people have. A lot of those problems are based on something going wrong in embryology or when the baby is being developed inside the womb.
Oh, okay.
So when those problems arise and the brain or the spine or the spinal column doesn't form in a normal way, sometimes that's something we address surgically.
Okay. Are those the most common pediatric conditions you treat?
Those are probably the most common. Certainly, just like adults, we see kids come in with trauma. We see kids come in with brain tumors, vascular abnormalities. We treat kids with epilepsy. But because our patient population is so young, we're capturing a lot of those problems early on. Those problems get titled under that big umbrella of being congenital, which just means they happened in the way we developed. And so it's not that we developed normally and something went wrong afterwards. It's something in the process of developing went astray. And if we can correct something surgically to improve people's function, we want to.
So how do you treat those congenital malformations with surgery?
It depends what it is. A couple that come up commonly involve the spine. And I talk to parents in clinic, in a very basic sense, we know that different layers of the body form at the same time. And so the skin may form at the same time that the underlying structures form. And so if there's an abnormality of the skin on the low back, that might flag us to say, could there be an abnormality of the spine underneath it? When there's an abnormality like that, is that something that's going to hinder a kid's ability to develop? Could it cause problems with the muscles of the legs, with the function or control of the bowel and the bladder? If something like that abnormal formation causes pulling or tugging or what we call tethering on the spinal cord, those nerve roots and the nervous tissue doesn't get to form normally or function at its optimal capacity. So we want to do what we can surgically to untether or kind of unstick the bottom of the spinal cord so that it's not being pulled or stretched. And that allows that function, we hope to catch it early enough that we don't lose function, but we ultimately want to make sure that we protect that function as the kid grows.
Okay.
Other problems can happen in the way the brain or the skull develops. And so depending on what the problem is, we either address the neurologic tissue or the skull kind of being what houses the neurologic tissue, making sure that we have protection for the brain, but nothing is under pressure or, constricting the normal brain growth.
What about hydrocephalus? I know that's fairly common condition. What is that and how do you treat it?
So hydrocephalus is very simply put, it's too much water on the brain, hydroencephalus. When we develop, we should all have a brain sitting inside the skull bathed in water or what we call spinal fluid. And that spinal fluid also lives in fluid-filled spaces inside the brain. Those develop as our brain is developing in the womb. And what can happen, because that water is constantly being produced by particular cells, it has to travel through macroscopic but very teeny tiny channels that are a couple millimeters big.
Oh, wow.
It has to travel through those channels, and then it also has to get reabsorbed in microscopic areas of the brain. If either of those two pathways get blocked, we have a buildup of fluid, and so that becomes hydrocephalus, or too much water on the brain. There's a couple different options for treating it, and it really depends on anatomy and reason for the blockage as far as how we treat it. Mm-hmm. The long-term kind of gold standard, most historically kind of have that longevity data, is to place a VP shunt. And it gets that name because it's tubing that basically takes fluid from one area and moves it somewhere else. And it goes from the ventricle inside the brain, that fluid-filled space, all the way down to the peritoneum, which is kind of like a water balloon inside the abdominal wall that holds the intestines.
Oh, okay.
So it's not going into your stomach or into your intestines. It's going to that sac that already holds the intestines.
Them all together, yeah.
And that works really well for all types of hydrocephalus because we're basically moving the fluid from the brain where it's either blocked or can't be reabsorbed, and asking that lining of the belly to do the reabsorption instead.
You're just creating another pathway.
Exactly. There's a newer option that really doesn't work for every case, but if the anatomy is right and the reason for the blockage is just that a blockage, not a reabsorption problem, it can be a great alternative. And that process is called it gets a fancy name. It's called an endoscopic third ventriculostomy, which is a mouthful.
That's a big one.
And it gets that name because we use a camera, so endoscopic, using a camera. Mm-hmm. Third, because there are 4 ventricles or fluid-filled spaces, it, by name, is a whole ostomy that we create in the third ventricle. So altogether, endoscopic third ventriculostomy, or to make it easier, an ETV.
Okay.
That procedure gets done by putting a camera into the fluid-filled spaces and then carefully navigating through the channels that are there and making a new hole to allow kind of what I think of as an internal detour. Okay. So it allows the body to still kind of control the fluid, but if you're blocked at a right turn, let me give you a left turn option. So it
kind of like bypass surgery.
Yeah. Basically, it's just internal plumbing.
Yeah. Okay. Well, you got a couple options there for hydrocephalus. What about brain tumors? I know there are many different kinds of brain tumors. Are they more common in children than people might think?
They aren't common, but like we say about anything rare, it's not common, but when it affects you, it's 100%.
Yeah.
When we look at national data, we see about 40 tumors of the brain or spine in kids per million patients.
Wow.
So it's not common.
That doesn't sound like a lot.
It's not common.
Odds.
There are a handful of different kinds, and here again we see a significant difference than in the adult population. When we deal with peds, our pediatric patients, we think of the variability at what does it mean to get diagnosed at different ages. The most common tumors change dramatically based on your age at diagnosis. And so that plays a part on what I expect it to be and a huge part on how am I going to treat it.
Okay.
Surgical options change, and the location of where that brain tumor crop up changes based on age. In kids 2 to 20 or so, we see most commonly those tumors form in the back part of the brain, and that's called the cerebellum. Because of its function, we tend to see most kids present kind of with headache, nausea, and vomiting symptoms, which are symptoms of hydrocephalus.
Okay.
Because that tumor or growth in the back blocks one of the channels.
Wow. Okay. Well, that makes sense. Let's talk a little bit about pediatric epilepsy. Now, I know that you actually treat some kinds of pediatric epilepsy with surgery, and that's a pretty highly specialized surgery. Can you talk a little bit about that?
Absolutely. So surgery for epilepsy is becoming more and more commonplace because of what we are understanding over the most recent decades about epilepsy medications and development of children. What we have learned is that if we can, based on our workup, our MRIs and our EEGs or our brain wave studies, if we can identify a focal area that seems to be the source of seizure activity, we know that over time, medications will become less and less effective. And so if instead we can upfront remove that focus, then we have a better shot at being seizure-free or having a significantly reduced seizure burden for a whole lifetime.
Wow.
And that makes a huge impact on a young child's capacity to develop, to not have a lot of medication side effects, to have fewer hospitalizations, to be able to participate better in school. And so we want to take advantage of those improvements in both understanding of what's happening, understanding how the brain's responding to both seizures, medicines, and surgery, and where do we have the biggest impact. So making those big impacts at a young age has a really lasting effect.
Now, is that pediatric epilepsy surgery, is that only available here at WVU Medicine in our region, in our area?
In West Virginia, that's something pretty specialized, and so I partner personally with the pediatric neurologists, and that's a conference we have every month, a specific clinic we have together every month, so that we can bring in that patient population and talk about them as a group, so that they get to come in once and see everybody involved and get any imaging or workup that they need done and have kind of all the input at one time so that they can have that cohesive care and have a good game plan from everybody going forward, working together and figuring out, do we do medicines for now? Is there anything else we need to learn or study? Or do we think that surgery is the right option? And if so, what kind of surgery?
Okay. Now, probably a little more common, concussions.
Very common.
Sometimes very, very common. I've had a son that's had a few. Also, traumatic brain injuries. Now, do you usually treat concussions and traumatic brain injury surgically, or is that probably usually the last
Surgery
resort?
is a specialized kind of narrow window within the bigger umbrella of concussions. But we definitely take an involved role because we have the experience and volume of seeing a lot of traumatic brain injury or TBI. I definitely see more than most pediatricians or most pediatric intensivists even. And so being able to have some reassurance and provide guidance for parents is really important, because not only do we want to get you through your hospital stay, we want to get you back to enjoying school, learning at school, being effective with your time. And we've learned a lot about the response of the brain to trauma over the last several decades, and have really found that one of the biggest things we can do is prevent a second injury, because in concussion math, 2 + 2 does not equal 4. It equals 14 or 20.
Oh, wow.
And so having a second concussion in close time window from the first injury has exponentially devastating effects. And so we really want to do everything we can to protect kids in that window and to encourage them a really gradual return to activity. It's one thing to say, in a year you'll be better. It's another thing to be able to counsel them on how do I get there and how do I do that. And it's really, really frustrating. I can speak from personal experience to do the ups and downs of I feel fine today, so I'm going to do a lot. And then the next day you just feel absolutely miserable because you did so much. And it's the brain reminding you, hey, I can't process as fast. This is a little overwhelming. I need to take some time to recover. And so if we can help guide kids and their parents through that very gradual process that we call, as a title, we call it brain rest, and guide them through that, that's a lot less discouraging than having a big peak and valley, bouncing up and down type of experience. I'm all for kids getting back to school, but it doesn't help me or them or their teachers or their parents if they put so much work into getting to school, they sit there in class and can't participate or can't actually retain the information.
You can't fast track concussion recovery. You just can't work harder at it and make it go faster. I know. No. Yeah. And keeping kids off of screens and...
Yes, and that's a huge component, that any sensory input is activity for the brain. It's not just going out there and playing soccer. It's screen time. It's small talk with family. It's, doing the math homework. It's everything. And everyone's going to have a different experience, and you may have no trouble reading a book, but they find that the screens really bother you. And so trying to learn some of those nuances and figure out how do you get to participate in things you enjoy without having to really take a whole day off to recover is important.
Yeah. Good to know. Good to know. What about, what are considered the specialty programs of the WVU Medicine Pediatric Neurosurgery Department?
That's a great question. So things I tend to own, so to speak, or really find my passion with is the tumor kids. Those are they're my soft spot. As I used to tell my mom as I was choosing this kind of career, I wish a brain tumor on no one, obviously. But if you have one, I would love to be a part of the process of getting you to the other side, getting you through the hospital stay, getting you through the surgery, helping you understand what comes next, and walking the kids and their parents and their siblings through that experience. That to me is where I get the most reward in my job. So those are kind of my soft spot, so to speak. I really have enjoyed getting to do more of the epilepsy cases. Has been kind of a recent addition and a lot of fun. It's been very enjoyable to see the differences we can make for those kids. Those are two of the programs I'm kind of spearheading. My partner, Dr. Meltzer, tackles the other things we haven't talked about, craniosynostosis cases.
That
which is
a
mouthful as well.
What is that?
That is a congenital abnormality of the way the skull fuses. So we should, to be able to get out the birth canal, we should have plates or pieces of the skull, and they are separate when we're developing in the womb, and they have a pretty standard fashion of how they grow and when they should fuse. So we have what we call suture lines, where they fuse together,
Okay.
kind of front to back right up here, and then across like a headband, and then we have a Y back here.
Okay.
And they have a pretty standard time frame on fusion and how that affects growth, giving us a pretty standard expectation for head shape.
Is that usually in utero that it should be
It sh-
finished fusing?
No. So
Okay.
we want them to be open when we deliver so that they can mold
Okay.
to get out of the birth canal.
Makes sense.
And then it normalizes with brain growth and skull growth together. They should be happening at the same time. And the sutures being open allows the dramatic growth that we see of a kid's head. If those sutures close too early, then it limits growth in that direction. And so then we get areas that are too small, and other areas will get too big to try to compensate for the total volume of space that the brain really needs.
Oh, wow.
And so my partner, Dr. Meltzer, does those cases in conjunction with Dr. Brook from plastic surgery.
So that can be treated.
Absolutely. That's something that we take care of. Anything from abnormal head shapes of just some flattening in the back from how we position and back is best sleeping to the part where the sutures fuse too early. Within pediatric neurosurgery, we also have CP clinics, which is cerebral palsy.
Right.
We have spasticity clinics, which is something we can see with cerebral palsy problems or other kind of neonatal neurologic developmental issues. And we partner closely with the neurologists for those problems and how we find solutions for them.
So how do you help parents coordinate care among multiple specialist teams?
So right now we do our very best to try to coordinate in kind of informal or formalized what we call multidisciplinary clinics. So if I have a kid that had a tumor removed and I need to see him or her in follow-up, they may come in, get their follow-up imaging that day, see myself and see the oncology or the cancer doctors the same day. So we try to make that a single experience so that the parents can get all the information in a day or half day
Right.
instead of having to make multiple trips back and forth. We do the same if there's multiple providers needed for something like a problem with the nerves that go to the arm. I can see that patient the same day that the plastic surgeon sees that patient, same day that the orthopedic surgeon sees that patient. And so we try to coordinate as much as we can to help simplify the scheduling for parents.
Okay. So for people that are watching that are thinking this might be something their child may need, what's the best way to make an appointment?
The best place to start is with your pediatrician. If you have concerns that any of these things are going on for your kid, really getting a chance to talk to your pediatrician about what's alarming to you and what are you seeing as a red flag, and they can help you navigate if a referral to our clinic is the most appropriate place. And we're in constant communication with the pediatricians to say, yes, absolutely, we can be helpful. Could you get us some imaging ahead of time and try to help streamline that so that when you're arriving to our clinic, we have all the information we need.
So no self-referrals. That seems like a little complicated to self-referral anyway. But so what would you say here before we go for people that are watching? What's the most important thing you want our viewers to know about the WVU Medicine Children's neurosurgery department?
I think it really speaks volumes to how important the kids are to West Virginia. The hospital really wants to highlight their care and give kids a place where they're the priority. They're not just little adults, as our pediatricians frequently remind us. They really need a different perspective. They have different problems, and we need to recognize that and be ready to treat that with good, solid understanding of how their bodies work and how development plays a role. And the Children's Hospital is really going to allow us to expand that pediatric specific treatment to their families. Because when a kid has a brain tumor, that's not something, that diagnosis doesn't hit the kid. That diagnosis hits the
parents.
family.
Yeah.
It
Well,
hits the parents, it hits the siblings,
yeah.
and we need to incorporate everybody into their treatment process.
So you treat the whole family.
Absolutely.
Great. Well, Dr. Hamilton, this has been really interesting. I know we covered a lot of ground. Thank you for being with us today and, spreading this important information.
Thank you. It was nice to be here.
Great. Well, that brings us to the end of this edition of Tuesday Talks. If you're looking for more information about pediatric neurosurgery, you can always visit wvukids.com or wvumedicine.org/RNI. We'll see you on the next Tuesday Talks on March 1st when we'll talk about robotic head and neck surgery. I'm Mary Ravazio Menard, and on behalf of Dr. Hamilton and everyone at WVU Medicine, thanks for joining us and have a great afternoon.